Yeah.
Yeah. Hello, good morning, everyone. Welcome to another session by the Maharashtra Rheumatology Association. As you know, this is a student-teacher interface where we have a case presentation followed by a guest lecture. And this is for the DM, DNB students and the fellows of rheumatology and clinical immunology. Today, we have two renowned guest faculty for the case presentation. We have Dr. Shubda Kalke from Mumbai. She's a senior rheumatologist, an alumni of GS Medical College and KM Hospital. Then she had the privilege to work with Dr. V.R. Joshi. She has done fellowship from UK, and presently she is working in Mumbai. Along with her, we have a young and dynamic Dr. Kaustubh Telan from Nagpur. He's an alumni of Nair Hospital, TNMC, Mumbai. And then he did his DNB from Medanta Hospital at New Delhi. Subsequently, he was working in Mumbai. At present, he's an assistant professor and in charge rheumatology division, GMC, and SSH Nagpur, consultant rheumatologist. He also is a consultant rheumatologist at Arthritis and Rheumatology Center and Aridhan Super Speciality Hospital, Nagpur. So welcome both of you for the case presentation today. We have a student, Dr. Nidhi. She'll be presenting the case. And Dr. Nidhi, introduce yourself and you can start sharing your slides. It'll be like any other case presentation, history, clinical examination, etc. The faculty are free to stop the student and ask questions in between or at the end of every, after the history is over, etc. Okay, over to you, Dr. Nidhi. First, introduce yourself, and Dr. Shubda and Dr. Kaustu.
Good afternoon, everyone. Myself, Dr. Nidhi Bhutada. I am a rheumatology fellow in Sion Hospital, Mumbai. Today, I am going to present a case of proximal muscle weakness. 49-year-old female, resident of Kurla, housewife by occupation, presented with chief complaints of erythematous rash over face, back and hands since 1 year, inability to get up from squatting and sitting position since 8 to 10 months, inability to raise both upper limb above shoulders since 8 to 10 months, increased hair loss since 3 to 4 months. History of presenting complaint. Patient was asymptomatic 1 year back when she started having erythematous rash over face, cheek, nose, around eyes, which slowly progressed involving the back and increase on exposure to sun. Patient also developed lesions over dorsal aspect of hands involving the MCP joint. Patient noticed inability to get up from squatting and sitting position 8 to 10 months back, which was insidious in onset, gradually progressive, associated with pain in both the thighs. Initially, a patient was able to lift herself with support of upper limb, but later she was unable to get up even with support. Later, patient noticed inability to raise her arm above shoulders and even inability to comb her hair, which was insidious onset and gradually progressive in nature. Patient also has difficulty in getting up from bed and requires support. Negative history. Any muscle fasciculations or wasting. No history of any diplopia, ptosis or any diurnal variation of muscle weakness. No history of altered sensorium, loss of consciousness or convulsion. No history of any bowel or bladder or sensory involvement. No history of any dryness of eyes, dryness of mouth or glandular swelling.
Nidhi?
Yes, ma'am.
You finish the history and then I'll ask the questions.
No history of any Raynaud's phenomena, difficulty in swallowing, skin thickening. No history of any roughening and cracking of skin of tips and finger. No history of any recurrent oral ulcer and joint pain or swelling. No history of any fever, cough, breathlessness. No history of any drug or medication intake. No history of any weight loss or night sweats. Past history. No history of similar complaints in the past. Not a known case of diabetes, hypothyroidism, IHD or hypertension. No history of any tuberculosis in the past. Personal history. sleep, appetite, bowel bladder normal, diet mixed, and denies any addiction. Menstrual history, patient has attended menopause, patient has 2 living children. Treatment history, patient was started on tablet MMF 360 mg 202 and tablet prednisolone 50 mg as 1 mg per kg weight with tapering. Due to partial relief of symptoms, tablet methotrexate 15 mg once a week was added. Patient developed intolerance to methotrexate and discontinued medication, which lead to worsening of symptoms. Summary: 49-year-old female with history of erythematous rash and insidious onset, gradual progressive proximal muscle weakness in both upper and lower limb, without any evidence of distal muscle and without any sensory or bowel bladder involvement. Possibility could be idiopathic inflammatory myositis, dermatomyositis, or overlap myositis secondary to SLE.
Okay, so from your main complaints, Nidhi,
Um,
okay, then you went to hold on to negative history. You have said in summary what you are thinking about this patient. So obviously, when the patient complained of muscle weakness, what are your differential diagnosis you are thinking from the main complaints?
yes, ma'am. So, ma'am, patient mostly had a proximal muscle weakness
Hmm.
without any involvement of distal muscle weakness.
Hmm.
And even there was no any diurnal variation or associated muscle wasting or fasciculation, which I ruled out to involve the CNS causes like myasthenia gravis or ALS or any dystrophic myopathy, which may involve uh, ocular muscles and also distal muscles.
Okay.
Um, Even
Sleeping of chapels for neuropathy, right?
yes, ma'am,
Yes.
neuropathy and distal muscle involvement also.
Okay. When you asked about altered sensorium and loss of consciousness, what were you thinking? What were
Uh,
you ruling out?
Secondary to any trauma or secondary to any CNS cause which can lead to stroke, which can cause muscle weakness or any CNS involvement, ma'am, other than
What CNS involvement? You are telling me history like a proximal muscle weakness.
ma'am, any motor neuron disease or that can present with the CNS involvement convulsions along with weakness or any UMN lesion that can present with weakness because motor neuron disease has UMN plus LMN involvement.
No,
Okay.
but the
It
CNS
doesn't,
brain functions are not involved. No?
correct. Loss of consciousness, what were you thinking?
Ma'am, most involvement for stroke or vascular involvement, secondary vasculitis or something like that.
But that will not cause proximal weakness, no?
That will only cause focal neurological deficit.
Yes, ma'am, but CNS lupus, like overlap myositis, which if it is involving CNS, that can cause convulsions or altered sensorium.
Okay. So, see, the point we are trying to make is when you say negative history, make sure you have explanation for that because otherwise the examiner is going to catch you.
Yes, ma'am.
Okay.
Yeah.
I just had a question. I think one very important thing, especially in this patient with rash and muscle weakness, myositis, a very negative, a very important negative history you cannot miss out. Family history. So any particular family history you want to ask for? And you must ask every patient of suspected dermatomyositis.
Family, family history of any malignancy in family.
Absolutely.
Correct.
Yes. Yeah.
Dr. Kaustubh?
Yeah.
would like to ask?
Nidhi, was there any other history pertaining to malignancy have you explored in this patient? Because there is nothing but which seems to be very concrete. Like these patients in ages more than 50, especially ovarian cancer or pancreatic cancer or something like that, because just having a history of or weight loss or something like that won't be a contributory thing. So you should be somewhat more objective, especially having history of breast lump or any lymphadenopathy or any history of unexplained fever. Like unexplained fever history is not there in your history. in the history which I've extrapolated in this patient. And other most important thing is about involvement of the upper GI tract. So upper GI tract, was there any index event like whether there was nasal regurgitation of food or solid or liquids? And second thing, whether there was nasal twang which was associated, because the pharyngeal muscle involvement will also lead to some different diagnosis, which would be very much different from the case. And in your history, was this patient already a diagnosed case of myositis? Because you have extrapolated and highlighted that the patient was already on methotrexate and oral steroids. And because if that had been the case, then you should be also explaining that what had been the course from the index event up to diagnosis and post that, because it will carry the meaning in treatment aspect as well. So
Yes, sir. When she presented to us, she was already on treatment and she was diagnosed, previously diagnosed 1 year back. She was
okay.
started on MMF and Folitrex, but due to her intolerance to methotrexate and with MMF, there was an incomplete response. Patient
Fine. The treatment history is fine. Just the thing is that from an index event up to diagnosis and post diagnosis up to treatment, the history should be in a flow, so that we would be able to get that the patient is a case of this is diagnosis and the treatment which he has received has not been working. And if the treatment is not working, then we will have to explore that what are the reasons for it. Like if it's a case of secondary dermatomyositis, secondary to some, say, supports malignancy, then we'll have to address the issue of malignancy as well. Okay.
yes, sir.
Yeah. Dr. Shubda, anything else you want to ask?
Yeah, the course, as he said, see, you have written due to partially relieved symptoms. So we have to be very clear on what, since she is treated, what improved and what did not improve. And intolerance to methotrexate means what happened?
Ma'am, she had when started with MMF, she was not, when patient presented, she was not able to even get up from bed and had difficulty in doing daily work. But when started with MMF, she had improvement in symptoms and like she was now able to get up with support and at least walk. But there was not complete improvement or there was not more relief of all the symptoms. So methotrexate was added, but a patient developed GI intolerance to methotrexate and had stopped all the treatment before coming to us with
All the
worsening of,
treatment, so even MMF.
yes, ma'am, and so
Okay.
the symptoms had worsened.
Right. Okay.
Dr. Puneet, you would like to ask anything else before we go on to examination?
Can go ahead.
Yeah, fine. Just one comment, avoid using MMF and Folitrex. Use full pharmacological names of the medication.
Correct. Absolutely right, Kavita.
Yes, ma'am.
Yeah, go ahead. Yeah.
General examination. Patient is conscious, oriented to time, place, and person. Examined in supine position. Temperature 98°F. Pulse 90 per minute with regular rhythm in right radial artery. Blood pressure was 120/80 mm of Hg. Taken in right arm supine position. Respirated at 30 per minute. Saturation was 99%. No pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema.
Nidhi, go back
Yes.
to the previous slide. So explain why you did each of these.
Ma'am, pulse to, sorry, ma'am, to rule out anything like respiratory involvement or to rule out ILD, check for saturation and respiratory rate. To see any other lymph node or to see any other secondary cutaneous in SLE overlap involvement, I check for it. Sorry, to see for any other involvement involving other system, I check for icterus, cyanosis, pallor, or clubbing.
So
And
when do you see icterus with myositis?
no, ma'am, not with myositis, but with drug-induced or with as a part of routine examination, I have checked all the same.
So always when you mention something, na, you have to know why you have checked it. You don't do it as a general examination just as a finding. You do it for a purpose. Okay, in this pulse is 90. Is this normal?
Ma'am, it is on a higher side, but normal, in the normal range.
So she's resting, right? Right now at 90. So why do you think pulse would be 90?
Ma'am, she had like muscle pain and body aches. That's why she would tachycardia is there.
Okay, one thing is muscle ache. The other thing with these patients, when you have difficulty in getting up, every little, even breathing is an effort. See, her respiratory rate is 30. You said you checked for that. So it is not normal respiratory rate, right?
Yes.
So the breathing work is also happening. That itself can explain the pulse.
Yes, ma'am.
Yeah, so all these little things are important. Yeah, next.
Yeah, so lymphadenopathy and all could be because of an underlying malignancy lymphoma that you have to mention, especially in an inflammatory polymyositis.
Yeah, autoimmune, whatever you are thinking.
Yes, yes.
Yes,
And
ma'am.
icterus could be where there's a malignancy with liver involvement or metastasis, etc. So all are important findings. And the cardiac involvement can be there in many myopathies, where you can have
So pulse rate can be high because of cardiac involvement also. So all these things matter.
Yes.
So,
Yeah,
Nidhi,
Kaustubh?
one question that if this
Yeah.
patient is having having tachycardia of say somewhat 110, so what all DDs will you think of?
Good.
Ma'am, patient could have cardiac involvement due to myositis, like myocarditis, or arrhythmias can be there, or due to excess of pain, or patient may have tachycardia due to increase in effort, breathing efforts, and everything.
And
Due to
okay, how with this, if at all this patient is also having pedal edema, so what all differentials will you like? This patient of yours is not having pedal edema right now, but you have mentioned. So if you get pedal edema in this patient, what all differentials will you think of pertaining to the history which you have given?
it would be due to right heart failure caused by pulmonary hypertension secondary to cardiac involvement in myositis, or due to malignancy.
Why will malignancy lead to
Because
pedal edema?
If over genital malignancies or abdominal malignancies could renal malignancy could cause compression of the lymphatic or vasculature causing edema.
Okay.
Pulmonary hypertension is common in which kind of myositis?
Yes.
Pulmonary hypertension is common in dermatomyositis and antisynthesis syndrome, and even antisynthesis syndrome is more common pulmonary hypertension.
What are the features of antisynthetase syndrome?
Antisynthesis syndrome present with Raynaud's phenomena, fever, inflammatory arthritis, calcinosis, interstitial lung diseases, my, myalgia, and myositis.
So you have not said pulmonary hypertension in this.
More common features.
Okay. So which other disease is commonly associated with pulmonary hypertension?
Systemic sclerosis
Yeah,
is
so overlap myositis, na?
overlap myositis.
Yeah. Okay.
So you can get lymphedema as part of the disease activity itself.
It,
As part of the inflammatory myositis, you can get lymphedema.
it can be due to overlap it can be as a part of this disease also, and it can be
As part
also.
of disease only you can get lymphedema.
Yes.
Yes, what sir is saying is true that since proalbumin or albumin is an acute phase reactant as well. So if at all there is increase in the disease activity, there would be fall in the level of albumin. So just because of hypoalbuminemia, the patient can have lymphedema or a peripheral edema as well. Second important thing is if at all you are thinking in terms of SLE, like whether it's a case of really a case of overlap myositis, then it can be a reason that we have to explore the patient in terms of lupus nephritis. Third thing, what madam has pointed out is very correct that if at all we are thinking in terms of pulmonary arterial hypertension, right now the patient might not be, like on examination, patient not be having any features which are very much peculiar of scleroderma. But in terms of overlap, or if it's a case of systemic sclerosis, sign scleroderma, then we have to explore that the patient can have a pedal edema, and because of that, because of pulmonary arterial hypertension, the patient might be having pedal edema.
Yes.
Yeah, continue.
Head-to-toe examination. On examination of hair and oral cavity were normal. On face, patient has erythematous rash over cheek involving the nasolabial fold. Heliotrope sign was absent. V sign was absent. Shawl sign was present. Patient had Gottron's papule present. Holster sign was absent, and examination of joints were normal. Patient has erythematous rash.
Go back to the previous slide.
Yes.
Yeah, you have mentioned Gottron's papules or rash. So what is the difference between Gottron's papule and Gottron's sign?
Gottron sign
In which
is red.
condition?
Yes, sir.
In which two condition, like how to differentiate these two? What is the anatomical involvement? Can you explain? What is the difference between Gottron's papule and Gottron's sign?
Gottron's papules are present on the extensor surface of the hand, mostly involving the metacarpal joint or the interphalangeal joint, and there is a papule over it. If there is no papule, there is only erythematous rash. It is called Gottron's sign.
No. See, over here, if at all you are getting the rash, you may or may not get a papule, because in Indians, papules are usually not that commonly seen. But if it is the joint involvement, you are having a rash, you are having hyperpigmented lesion over that space, which may or may not be associated with papule, it is called as Gottron's papule. But if the interjoining part, the phalangeal part is getting involved and you are having an erythematous rash, which is usually scaly, it is called as Gottron's sign. So Gottron's sign is usually seen in patients with SLE, and Gottron's papule is seen in patients with dermatomyositis, or in fact, it is more commonly seen in juvenile dermatomyositis and not that common in adult myositis. Ma'am, please correct me if I'm going wrong somewhere. Shubhda ma'am.
Yeah, don't worry. Go ahead. No problem.
So this is what is the explanation which I have read. And what about Holster sign? Can you just let us know that the sign which you have mentioned, on which areas you find them?
V sign is present mostly in the neck, sun exposed area. Shawl signs are present over the back. Holster sign is present over the thigh and lateral aspect of leg. Heliotrope is present over the eyelids. Volious erythemata over the eyelid with edema.
Okay.
What is inverse? Just one second. What is inverse Gottron's sign? So Gottron's papules.
Papule is mostly present on the extensor aspect of hand. If it is present on the flexure aspect, it is called reverse Gottron sign.
Inverse. And what is
And
the
associated
significance
condition? In which condition do you get this inverse Gottron sign?
It is more commonly present in MDA5 associated dermatomyositis.
Yeah, and MDA5
and its clinical association. If you are having inverse Gottron, what is other clinical association the patient would be having?
Patient was having a rapidly progressive ILD.
Yeah, so we have to be more aggressive with treatment, like. Yeah.
Patient showing erythematous rash, which is also involving her nasolabial fold, and Gottron sign is present on the metacarpal phalangeal joints and interphalangeal joint.
Nidhi, just go back. So what differentiate between why this is not a lupus rash?
Lupus NASH does not involve the nasolabial fold. It spares the nasolabial fold, and also lupus lashes mostly involve the phalangeal and not the joint.
Yeah, okay.
Systemic examination, central nervous system examination, higher mental function, cranial nerve examination, and sensory examination was normal. Motor examination, tone normal in all four limbs, nutrition normal, power In upper limb at shoulder joint, power was 3 by 5. At elbow joint, power is 5 by 5. And at the wrist joint, it is 5 by 5. In lower limb, power at the hip was 3 by 5. At knee joint, it is 4 by 5. And ankle, it is 5 by 5. Manual muscle testing score was calculated, which was 106 out of 150. Reflexes, deep reflex and superficial reflex were normal. Plantar, both right and left were flexor. Other sensory examination was normal and other system examination was normal. Summary, 49-year
Nidhi, just go back to the previous slide of muscle examination. Yeah, in your general examination, you have stated that the patient was having a respiratory rate of 30. So it was definitely higher than normal. So did you check for diaphragmatic involvement in this patient? And if yes, then how did you check? Because you have not mentioned in the examination part.
Correct.
patient had a respiratory rate of 30, but her breathing pattern was thoraco-abdominal, which is normal in female. And for if there is a diaphragmatic involvement, the breathing pattern would change and it would be abdominothoracic.
That would be very late. It would be in the sign of diaphragmatic fatigue, in fact. So how will you check for diaphragmatic involvement? That reverse breathing would be seen when there is extreme fatigue.
We would check for patient. We would ask the patient to exhale and hold it, and we would percuss down the back in the intercostal margin, and we will see for dullness if present.
What you are explaining is about liver dullness. That I'm not asking about liver dullness. I'm asking how will you check for diaphragmatic involvement? Did you do single breath count in this patient?
Single breath count.
Yes, sir.
So how much it was single breath count?
Single breath count was 25.
You have not mentioned that, if
Yes.
I'm not mistaken.
No, sir, not mentioned.
Okay. And what else? What else test you can perform to see for diaphragmatic involvement?
We can do 6-minute walk test.
No, 6-minute walk test is not for diaphragmatic involvement, basically. In fact, 6-minute walk test was only introduced to look for sensitivity of pulmonary hypertension. We have now extrapolated it that it can be also done as a, I would say, marking parameter for ILD as well, but it's not very well documented and not very well evaluated as well. So no, definitely not 6-minute walk test.
And anyway,
you know,
with this
cough test?
weakness, it is not worth doing a 6-minute walk test in this patient.
Yes. Sniff test, cough test, have you ever heard of?
No, sir.
Can we do in this patient?
No, sir, not.
Okay, read it. And one more thing, like when you are mentioning about the proximal muscle weakness and other things which have been there. So if at all the patient is able to walk, like if at say some different scenario that we have to see that the patient is improving or not improving, other than MMT8, which other parameters can you clinically study in a patient pertaining to myocarditis?
We can see for muscle edema, sir, if it is improving, or 6-minute.
Clinically. For doing muscle edema, you will have to go ahead with MRI.
Sir, we can go for to see the 6-minute or 10-minute walk test or chair sit test for 30 seconds.
But if the patient is having muscle weakness, he won't be able to walk, right? So there would be some amount of confabulation with respect to the test which you are performing. I'm asking about clinically, other than, I will simplify the question, other than MMT8, what are the other ways to test muscle power clinically?
There is a myocytic functional index for myositis, which is used to test.
So have you heard of IMAX?
No.
Fine, no problem. So about most important thing over here is diaphragmatic involvement is important because you are dealing with a patient of myositis, and single breath count is very important in this patient because that will also lead to prognostication of your case. Okay, carry on.
Did you check for, so sorry, I did missed out. The neck weakness was there.
Yes, sir. Neck weakness was there.
Yeah, so then you should definitely look for diaphragmatic
Yeah.
weakness. Other than, did you check for gag reflex?
Yes, sir. Gag was normal in cranial nerve examination. We have done. Summary. 49-year-old female with erythematous dermal rashes, papules, bilateral symmetrical proximal muscle weakness of both limbs and neck with preserved superficial and deep reflexes without any sensory involvement. Possibility could be idiopathic inflammatory myositis, dermatomyositis with inadequate response and intolerance to methotrexate and mycophenolate mofetil. Blood investigation. Her complete blood count was normal. Her ESR was 85 mm per hour. CRP was 1800 mg per dl. Renal function tests were normal. Her liver function test shows AGOT of 136 international unit and SGPT of 119 international unit. ANA by
Go back to previous slide. Nidhi, go back to previous slide. So if the patient like yours, the patient of yours had been on methotrexate, had been on MMF. So what all things will you see in patients? Like what things in CBC will you like to monitor pertainingly?
WBC would be like, we would like to monitor to see for leukopenia. We would like to monitor RFT with creat to see for any renal toxicity, on even liver enzymes for deranged bilirubin or LFT, and for
I am
skin.
asking only about CBC. What things in CBC will you like to see?
We will also see for HB and MCV for anemia, HB and MCV we can see causing
And
and WBC counts.
Differential count.
Leukopenia for
Are you talking about CRP here or CPK?
Yes.
Or what do you?
CRP is way too high.
Are you sure that the correct value in
Yeah.
thousands? I'm not. I think it's a writing error. I think no.
Yeah, I think so.
184 or something.
How much? 184 was very high actually in
Yeah.
a case of.
Yeah.
Do you expect such high CRPs in inflammatory myositis?
So it is 18.4, not 184.
Oh, okay. Oh, then that's okay.
Yeah.
counters usually don't give value more than 200. Like they will just mention
Correct.
it more than 200.
It is 18.45.
Fine. You are sorry, you have to complete Kaustub's question. I intervened.
WBC में more details about WBC count.
Yes.
We will check for leukopenia
Yes.
and
What in
raised
leukopenia? What in leukopenia? Anything particular?
lymphocyte. Lymphocyte count will go, which will be more reduced.
Neutropenia, no? Am I able to hear you?
Yes, sir. Yes, sir.
Absolute neutrophil count is important.
Absolute neutrophil count, especially if at all the counts are less than the normal value, and even in prognostication as well.
Yes.
About platelets? Is it
So
important?
platelets, there would be also thrombocytopenia could also be there due to toxicity of methotrexate.
Okay. What in liver functions? Typical of?
The total bilirubin would be raised, even in liver enzymes will be raised.
So
And
SGOT of 136 and SGPT of 119. Can you differentiate that this is having a muscle origin or it is having hepatic origin, because you are having OT which can be liberated from muscles as well, right?
yes,
So this is derangement of SGOT and SGPT is because of muscle involvement or is because of liver involvement? How will you, I mean, you can get somewhat idea.
We'll have, these are not muscle specific, so other liver enzymes will have to test like gamma glutamyl transferase, and it is ALT more than AST. Here it is AST more, which is not specific for muscle involvement.
Okay. Anything from just from LFTs you can get?
We can, like, other liver enzymes are normal. If transamine,
Having hypoalbuminemia in your patient, it's 2.9. Okay, proceed. Proceed.
ANA by IF was done, which was homogeneous 3 plus. ANA blot was suggestive of AMA M2 positivity. Her total CPK was 1800, LDH was 1500, and aldolase was 14.4. Myositis profile was done, which was suggestive of MI2 alpha positive and beta positive. Thyroid function was normal. HbA1c was 5.5 and her urine RM was also normal. EMG NCV studies were done. Studies suggestive of primary muscle disease involving bilateral upper limb and lower limb. Proximal muscle like deltoid, gluteus maximus are more significantly involved, showing abnormal electrical irritability with short duration and low amplitude motor unit potential with active ongoing denervation suggestive of inflammatory etiology. Other investigation, HIV, HbSAg and HCV were negative. PET-CT was done, which was suggestive of no evidence of any uptake suggestive of malignancy. Final diagnosis, dermatomyositis.
Go to previous slide, the previous one. Yeah, this one. Will you like to do myositis profile every time in the patient of dermatomyositis? Because it is
Yes,
not easily available, right? And it's too costly.
Quite expensive.
And
so if many a time in patient with muscle weakness, ANA blot would be negative. In that case, myositis profile would help to differentiate and what are the antibodies involved. If
okay.
possible, will
Anything else?
in even myositic, like in cases of malignancy, myositis specific antibodies will be help to figure to know the causes to detect the prevalence of malignancy in such patients.
Then why not to evaluate for malignancy? Why just for myositis profile?
So we'll do both. We'll evaluate for malignancy also in high risk patients.
So what is high risk patient?
Age more than 50 years, with male
Will be
gender.
there with most of the myositis, right? Except for SLE and so on.
With male gender with difficult to treat the disease or with relapsing disease or with patient with TIF1 alpha or NXP2 positive myositis. It is necessary, will high risk patient for malignancy and will screen for malignancy.
So will you do
So,
myositis specific myositis profile in every patient as Kaustubh asked? So which
Um,
patient you will do and which patients you know there is no need to do?
If ANA blot is positive, ANA is positive and ANA is suggestive of MI2 positivity, so we can go, this MI2 is not that much risk for malignancy, so it is not necessary to do myositis specific profile. But the ANA is negative, ANA blot is negative. So myositis profile is, we'll go for myositis profile to look for other antibodies.
So myositis profile will give you what antibodies and what will be the significance?
Myositis profile will give myositis specific antibodies, and each antibodies are exclusive with some features, so we can to rule out malignancy or other associated complications. Myositis profile would
Correct.
be
So I'm asking you that only. Yeah,
uh,
apart from MI, what is there in myositis profile and what
we go
indicates?
for NDA5, TIF1 gamma, NXP2 and SRP in myositis specific antibodies.
Okay. And
And
There are a lot of them.
anti-Jo1 antibodies, and for C1 for C1NA.
Which are the anti-sensitive antibodies which come in the myocytic profile? You have some 4-5 of them that come together.
yeah.
Which are the ones?
Anti-Jo1
जो आपने बोला फिर आपने
Jovan to बोल दी. Other
anti-Jo1
than Jovan.
PL7 PL12, then it is anti-EJ
Yeah.
EJ, OJ.
Yeah,
anti-EJ antibodies, anti-OJ antibodies are present.
correct.
So Nidhi, what are those MAA and MSA, like myositis associated antibodies and myositis specific antibodies? So can you highlight what are these two these two different
Myositis
antibodies?
associated antibodies would be PMSCL70, anti-Rho, anti-La, KU, and UNRNP. Myositis specific antibodies are anti-Jo1, MDA5, TIF1 gamma, and NXP2, and SRP antibodies. MI2.
MI2, right?
Yeah.
What are the indications of muscle biopsy in patients in this person, any patient, if coming to you with somewhat clinical suspicion of myositis, will you like to do muscle biopsy in every patient?
So muscle biopsy would help to, like if possible, we'll do muscle biopsy. It will help to differentiate, like it will help in diagnosing, it will diagnosis, specifying the diagnosis only.
But you are doing myositis specific antibody, na? Do you need to do biopsy and myositis specific antibody both?
If it is available, we'll go for both. If not, then myositis specific antibodies would be help.
Both are available. So every case you will do both?
So if if in every case it is not needed, if the diagnosis is confirmed, but if there is any queries, we will suspicious, we'll go for muscle biopsy.
So
This
here,
What
question
is
I will
that
do.
query? What is that query? If you have that query in your mind, so when will you subject a patient to muscle biopsy? See, you are having all facilities at your center. So which are those specific patients will you like to go ahead with muscle biopsy?
So when the myositis specific clinical picture of the patient and the myositis profile is not correlated, we can go with muscle biopsy. And even in cases, some patient may have a negative, if
Negative. And in one most important, nowadays the incidence is going high, that is necrotizing myositis.
myositis.
So if at all the clinical suspicion is that of necrotizing myositis, we cannot document necrotizing myositis just on the basis of any antibody, because HMG-CoA anti-HMG-CoA antibody is not routinely available in the myositis profile. Anti-SRP is there, anti-HMG-CoA is not there. And incidence wise, it is higher as compared to SRP. So if the clinical suspicion of necrotizing myositis, if all the antibody and the immunological workup has come out to be negative, in the conditions wherein there can be an overlap, or in which the clinical suspicion is very much different from what objectively you are getting. So in those circumstances, it would be better that you document the patient on muscle biopsy. So,
Actually,
uh,
yeah, agree.
so you carry on, you
Also in
So
inclusion body myositis, you need
So
to.
the only thing actually, I think most important, if the patient has typical rashes, the patient doesn't need a muscle biopsy. Very clear. That is not going to help. But if a patient of polymyositis, there's no rash, that is when I would consider a muscle biopsy. And yeah, I think that because at that time to send the myositis profile also, the antibody, but also in a case of polymyositis, getting a muscle biopsy, I think I would rely on that because it's a long-term diagnosis. We shouldn't be missing out. So
And in conditions wherein neuropathy and myopathy, like especially inclusion body myositis,
Yes.
the diagnosis can't be made without a biopsy. So that atypical type of a distal more than proximal and a typical sparing of few muscles if it has been there, because there is no antibody which is been associated or found out to be that much specific for inclusion body myositis. So inclusion body myositis itself is the diagnosis which can be made on the basis of biopsy. So 2, 3 indications, like from mice, it would be a case, suspected case of necrotizing myositis, inclusion body myositis, and wherein, like what sir has said, to differentiate between polymyositis versus others.
What is an
Myopathy.
important cause of necrotizing myositis?
Necrotizing myositis is present with drug-induced myositis, most commonly seen with statin.
Yeah, young
Yeah.
patients, high dose statins given post, PTCA. Okay. I think we have about, yeah, but say 4 or 5 minutes. So I request the faculty to just, sort of conclude the
sure.
case and give a short small feedback.
Should
Dr. Nidhi, conclude your case
Yes.
by
Treatment, as patient has inadequate response to mycophenolate, mofetil, and intolerance to methotrexate. Other options were given to the patient like rituximab, azathioprine, and cyclophosphamide. Injection cyclophosphamide 1 gram was planned. Patient has now received 3 doses of cyclophosphamide. Her MMT score has improved from 106 to 126, and her liver muscle enzymes has reduced. Her total CPK is 1000, LDH is 500, and aldolase is 9.8.
May I just ask why cyclophosphamide? Why not other therapies? Like, for
So
example, a methotrexate with CNI combination, or
patient develops her intolerance to methotrexate. So
what
methotrexate, she
what
had
dose of methotrexate was going on?
the patient was on 15 mg once weekly dose.
Okay.
She had GI symptoms, so methotrexate was not given. And in view of patient's affordability and follow-up, cyclophosphamide was decided.
What about tofacitinib, JAK inhibitors?
Tofacitinib had a like patient with predominant arthritis features. Tofacitinib will be very useful in that case. Even tofacitinib can be used.
Nidhi, have you heard of RIM trial or ProDerm trial?
Yes, sir. RIM trial is the use of rituximab in dermatomyositis, and ProDerm trial is the
Myositis.
yes,
It's
sir.
whole for myositis. RIM is in myositis, not just for dermatomyositis.
RIM myositis, and ProDerm is the use of IVIG in myositis.
Yeah, so do you know about any highlighting points about when to use rituximab, when to use IVIG in patients? Like, what are the indications of IVIG in dermatomyositis?
In case of severe cases, acute patient has come with acute features with like severe. In case of severe diseases, IVIG will be can be used and it has a good response. And
So
in
what do you mean by that severe disease?
patient has respiratory
Objectively, it should be
involvement.
having,
Patient is having
okay,
respiratory
one is
involvement,
respiratory involvement, other.
dysphagia, aspiration pneumonia. With in such cases, IVIG will be more useful. Or with rapidly progressive ILD, also IVIG can be given.
Okay. And
If,
in resistant cases, like we
treatment,
patient can be on a 2 monthly or a 4 monthly plan of IVIG. This is the treatment option which is being
they
usually
have
given in the
given
patient.
every 4, like in Proderma trial, IVIG has been given every 4 weeks till 6 months to the patient.
Anything more important which has been concluded from the prodrome trial?
I guess so.
Okay.
Okay. I think we'll conclude
It
the
was a nice
Q&A.
presentation, Nidhi. You
Yes,
have
sir.
highlighted most of the points, but few things about diaphragmatic involvement. And there has to be some correlation between the scale of events which had been occurring in your history. Like you should be able to note the things in that order. Like what was the index event? How was the progression? Then when was the patient diagnosed post that? Like jumping directly on that patient was on this is medication. Then usually not boil down to something which would be clinically that important.
Yeah.
And especially when you are dealing with a patient of myositis, respiratory involvement and upper GI involvement needs to be definitely checked in your and diaphragmatic involvement in your clinical examination. That cannot be avoided.
Yes, sir.
Yeah. Shubda?
Uh, Nidhi, first I want to say that you have presented well. Don't worry about what we have pointed out, but it is important to go through and ponder on what we have said, because what we are trying to do is not just find your faults. What we want you to do is think, because tomorrow you are going to treat this patient on your own. And all these little points you should be able to do. Exam is one thing, examiners will point out things, but tomorrow all whatever has been said to you is not to point out your mistakes, but this is how you have to think when you are faced with the patient and when you have to treat the patient. Why Kaustubh said why you have to do origin, duration, progress is most of the decisions are most of the times made on the history and what you find on history, and you just confirm it on examination. So you have to start thinking in that term, and that is what we want you to do. So
Yes,
just
ma'am.
keep in mind.
Yes, ma'am.
Dr.
And
Puneet?
even if you are not spending, the patient is in spending. So it is not the matter of availability. It is the importance of the test in which you do the test, not just because it is available.
Yes, ma'am.
Yeah.
Dr. Puneet, any comments?
I think very well presented. I think only the points which are missed out have been covered.
Yeah, yeah. So after all, it's a learning exercise, and I think it was a good academic discussion. The other students have learned a lot and carry home to read more. So thank you, Dr. Shubda. Thank you, Dr. Kaustubh, for a very interesting academic session and a good question answer in sequence. So we move on to the next part of our session today. We have with us Dr. Puneet Mashru from Mumbai. He's a consultant rheumatologist and head of the department at Sir H.N. Reliance Foundation Hospital. He's also attached to Beach Candy Hospital and Jaslok Hospital. He's also certified clinical densitometrist by ISCD USA. We all know him for his excellent lectures on management of osteoporosis. And I'm sure after today's talk, we'll have a lot of take-home messages. Over to you, Dr. Puneet.
Yeah, thank you so much.
Yeah.
So
Start.
it's a lot to cover, and so we'll start.
Yeah.
My slide. Yeah. Okay. So osteoporosis is defined as a skeletal disease characterized by compromised bone strength, leading to increased susceptibility to fractures. And the bone strength depends on two factors, and it's bone density and also the bone quality. So this is very important to keep in mind, because as a routine practice, we are looking at only bone density. And we all know osteoporosis is extremely common, more common in female. 1 in 3 women above 50 will experience osteoporotic fractures. And these fractures are serious. They reduce lifespan, quality of life, and especially hip fractures, the mortality is quite high. So these are serious fractures. And we know it's more common than heart attack, stroke, breast cancers. And why do we get osteoporosis? So we attain our maximum peak bone mass by age of 25, and that the attainment of peak bone mass is multifactorial lifestyle, which includes also sleep and your calcium intake, your also genetic factors. And then in women, when they attain menopause, there's a rapid bone loss. They lose 10% of bone mass at the time of menopause for that 1 decade. So that's almost a T-score loss of on the DEXA that you get after menopause. And yeah, etiology can be primary or secondary, and that's
So Puneet,
secondary
your
cause.
sound is cracking a little. Can you just check your...
Yeah, am I audible now? Hello. Am I better now? It's audible.
Yeah.
Secondary causes are multiple. I think we all know this: hypogonadal state, hormonal conditions like diabetes, thyroid, hyperparathyroidism, GI conditions, blood disorders like hemophilia, and multiple rheumatological conditions, not only rheumatoid, and drug-induced osteoporosis, PPIs, and glucocorticoid-induced osteoporosis. So how do we diagnose osteoporosis? Either somebody's had a fracture, which is a fragility fracture. So definition of fragility fracture is a fracture occurring spontaneously or from a minor trauma such as a fall from a standing height or less. Or we use DEXA scores of a T-score of less than minus 2.5. Or we use FRAC scores where the major osteoporotic fracture risk is 10.5% or more, or hip fracture risk is 3.5% or more. So these are the FRAC score are the Indian cutoffs that we have. The Western cutoffs are different. So what is a fragility fracture? As I told, fractures occurring spontaneously of a minor trauma, such as fall from standing height. The most common sites of fragility fracture are spine, hip, wrist, humerus, ribs, pelvis. What is not osteoporotic fractures? They're skull fractures, cervical spine, hands, feet, and even stress fractures are not considered as fragility fractures. And there are various BMD ways, different ways to measure BMD, which include peripheral, there's ultrasounds and peripheral DEXAs. But DEXA scan is the gold standard and most commonly used. QCTs also are there. And we use T-scores in postmenopausal women and men above 50. BMD of more than 1 is normal. Between -1 and -2.5 is osteopenia, and -2.5 and less is osteoporosis. When we do DEXA scans, we must also ask our center to do a lateral DEXA. If lateral DEXA is not possible, we should ask them to do a spine X-ray, and we should ask in all patients. So this is for Western population, above 70 and 80. Indians actually, we can minus 10 years. So anybody above 60 years, women above 60 or men above 70 years, we must ask for a spine X-ray because these fractures can be 60% of them can be silent. These are also essential in patients who are on corticosteroids, and because you can get fractures occurring even when the bone density is not too bad. So in this study from Vellore, 36% of women above 60 had at least one moderate vertebral fracture, and if you can see, almost 40% of them were either osteopenic or had normal bone density. So and these are just a general population. This is not our sick rheumatological patients or patients on steroids. So let's go through some cases. So we just get an idea of what it is. So 71-year-old female, your DEXA score of spine, the spine minus 2.1, hip is minus 2. Mother had a history of hip fracture. So what next do we do? This patient is not osteoporotic technically, right? Based on the T scores, and the patient has never had a fracture. So what next do we do? So we must look at the overall fracture risk for this patient. So we used a tool called FRAX that combines BMD with clinical risk factors. And so how do we use it? We go to Google, we type FRAX, then we go to the Indian data, we choose Indian, and we put the age, sex, weight, height, and we put in certain clinical risk factors like previous fracture, parent fractured hip or not. So parent fractured hips are supposed so that caveat is if they're fractured at 80 years or less. If it's above 80, then again that will be a no. Current smoking, corticosteroid use, patient of rheumatoid arthritis or not. If the patient is diabetic, you can still make the RA test, yes. And secondary osteoporosis is a dummy if you're putting your BMD values. And we put in the your hip score, and then you get a reading here of major osteoporotic fracture risk and hip fracture risk. And if you get beyond this, you cut off a 3.5 and major osteoporotic fracture risk of more than 10.5%, it is osteoporosis. There's also something known as FRAX plus, because FRAX by itself, there are some drawbacks. For example, it doesn't take in consideration multiple other risk factors. For example, even patient diabetic, how many years diabetes? Did a patient have a fracture? How recent was the fracture? More recent, the higher risk of fractures. So there's a tool called FRAX Plus, which is a paid software, and you can adjust for one of these factors, not having multiple factors that include recency of fracture, glucocorticoids, then trabecular bone scores, adjust with diabetes, recency of fall, and if there is more than one standard deviation between your hip scores and your spine scores. So if that is, then that also can be adjusted. And the last one is hip axis length. How do you evaluate for osteoporosis? So all patients with osteoporosis must have a complete blood count, do ESRs, calcium, phosphorus, kidney function, ALK-phos, vitamin D, and thyroid functions. And if there is some abnormality or we are suspecting a very young individual having very low bone mass, then maybe additional testing like PTH, TTG, or in elderly individuals who had spine fractures or have anemia, high ESRs, protein electrophoresis in those patients. This is 16-year-old female, postmenopausal since 10 years. DEXA score, she's osteoporotic, minus 2.6 at the spine, hip is minus 2.1, and there are no additional risk factors. So how do we want to treat this patient? So all our patients, this is universal recommendation, adequate calcium intake. I'll just say a couple of things of calcium is that there was some data regarding increased cardiac risk with calcium intake. So the cutoff of the cardiac risk is 2,500 milligrams of calcium a day. If you take more than that, then the cardiac risk is high. So that is why if you're giving calcium supplements to our patients, give only one tablet a day, that should be enough. The other thing with calcium is that does it actually reduce the fracture risk? The evidence for fracture risk reduction and bone density increase is very plus minus. So some centers don't even recommend much of to give supplemental calcium to their patients, especially in places like New Zealand where already they're taking enough of dairy. Vitamin D, adequate intake of 800 to 1,000 international units per day. Protein intake is very important, and that gets missed out often in our patients of osteoporosis, talking about sarcopenia. So to prevent sarcopenia, a protein intake is extremely important. Regular weight-bearing exercises, balancing exercises, fall prevention measures, and avoiding tobacco, alcohol, etc. And identification and treatment of risk factors. For example, if any elderly patient, is at high risk of falls, getting them assessed for cataracts, improving the vision. So all those things also, small things, but make a very important role actually. These are all fall prevention measures that we must go through with our patients. Weight bearing exercise, there is no age of weight bearing. This is a 95-year-old lady who is doing weight bearing exercises. She's doing power lifts and other things. Now, these are all our treatment options that we have. So treatment options are divided into two parts mainly. One is anabolic and other is anti-resorptive. In the anabolic agent, we have teriparatide. We have romosozumab, which has a dual action, anabolic and anti-resorptive. In anti-resorptives, we have intranasal calcitonin, which is not much used anymore. It is only used for if the patient has a spinal fracture and just to get to reduce the pain, and that is the only role that it has at present. Then hormone therapy, raloxifene, bisphosphonates, which are either oral or IV, and then you have denosumab. When we are planning our treatment, we also have to understand that every treatment works differently at different sites. So, for example, ibandonate has not shown to reduce the fracture risk at the hip and the non-vertebral sites. And teriparatide has years mentioned that no effect on hip, but I will show you some data that actually it does help. The other thing we have to keep in mind when we're managing our patients is that the adherence to therapy is very poor. These patients, because it's a silent disease, the patients are often not compliant. So in one study, only half patients adhere to oral therapy after a year, and 13% patients never started treatment after giving a prescription for osteoporosis. So how do we improve compliance? It is by giving IV zoledronate. I think that is a wonderful drug and should be considered in our patients improving oral therapy. Side effects with the oral agents, GI intolerance, hypocalcemia. To prevent it, we must check the calcium, vitamin D. First, correct the vitamin D and then start the treatment. And we should also check for calcium after 4 weeks after giving the treatment. For renal dysfunction, we have to be careful. So we avoid if the GFR is low, less than 35 ml per minute. And IV Zol, we have to give slow. We give over at least 15 minutes. I usually give over half an hour, 45 minutes. There's no hurry. Then comes musculoskeletal pain. It's rare. I've seen 4 or 5 patients who had these musculoskeletal joint pain, some joint effusions happening, which I've seen with IV Zoledronate. Flu-like symptoms is very common. So 50% of patients with IV zoledronate will develop flu-like symptoms. And they usually last for 3 to 7 days. And to prevent this, we usually used to prescribe paracetamol, but there is data that if you use dexamethasone 4 milligram for 3 days, in most patients, the symptom will not occur. So we are very scared for this side effect, and it gives us a bad name. But I think using dexamethasone along with IV zoledronate has really improved the tolerance for IV zoledronate. Then atrial fibrillation and esophageal cancer, actually, there's not much increase. There was a doubt before. ONJs and atypical fractures, I will come talk about later. How often do we give IV zoledronate? There's data that so the standard dose is once a year, but there's data also that shows that IV zoledronate is a very long-acting drug. So even giving once in 18 months is not a bad idea. So I often would do what I would do, I would do a baseline bone toner marker at baseline, and then after the year, repeat the bone toner marker, and I would usually give the next dose after 1.5 years. And often I would see that the bone toner marker is still suppressed. So it definitely works, and there's enough literature now to show that once in 18 months should be good enough. So in our patient, we give IV zoledronate. This is another patient. She came in, she was very anxious and very tensed, and she took an emergency consultation saying that her radiologist told that she's very high risk of hip fracture. And her neck femur is minus 2.6. And so this is a scan. She's 47 years old. She's premenopausal. So we don't look at T scores, we look at the Z scores. And the Z score is normal. So if the Z score is -2 or less, then bone density is low, but not osteoporotic. So we must use Z scores in premenopausal women and men less than 50. Next, 26-year-old female, postpartum, she had a lot of body pain. So this was the patient actually done 15 years back when still bone density and osteoporosis was very new, and the gynec also did not understand much. And here this patient went to the gynec, and the gynec asked for a DEXA scan, which was actually incorrect. It was done, and you can see that the Z scores are extremely low, extremely low. But this patient had osteomalacia, vitamin D, calcium was low, PTH was high, alk phos was high. So this was osteomalacia and not osteoporosis. And just correcting the osteomalacia, the bone density is normalized. You can see the Z scores are normal now. And there was almost 60%, 60-70% improvement in bone density just by correcting the osteomalacia. So dramatic improvement in this. Next patient, 38-year-old female, low back pain, acute onset after lifting or shopping back. So again, this patient was around 9 years back, and an X-ray or the spine was done, and she had a L1 vertebral fracture. The DEXA scan was advised by a spine surgeon, and you can see that there is an increased sclerosis here on the DEXA, and her bone density is very low. These scores are very low. the spine and the hip. And the orthopedic discussed vertebroplasty and teriparatide, and she had come for second opinion. And her labs were done, her calciums were high, PTH was high. So this was basically she had a parathyroid adenoma, which was picked up on the system scan. And just by doing the surgery, the bone density normalized. You can see the dramatic improvement. Normal Z scores now. 72% increase in bone density, 72% increase in spine bone density. This you cannot get with any drug, and that's not possible only. So just correcting the underlying cause just dramatically improve the bone density. So take-home message is that a DEXA scan cannot differentiate between osteoporosis and osteomalacia and other metabolic bone diseases. So we must always look at secondary causes, especially in younger individuals or when the BMD is lower than what you expect. Coming to the next case, this is a 42-year-old female. She underwent a hysterectomy 1 year back, and she had hot flushes. And as part of a health checkup, she underwent a DEXA scan where the spine T-score was minus 2.7, it was minus 1.8. Now, these are all our options. She was sent to me saying that she's osteoporosis. What do you want to do? So what options do we want to give? When we decide our treatments, we have to always keep in mind that there is a fixed duration with which we can use our drugs. We can use our drugs so far for 30 to 40 years. So if we start using it very early, then when the patient is really elderly, then that time we will not know what drugs to give, or we'll be hesitant in using the drugs, weighing the pros and cons of the side effect of the drugs. So unless contraindicated, women with premature menopause who require prevention for bone loss, they must be given hormone therapy rather than bone-specific treatments. So until the average age of menopause is achieved. So this is the early menopause. So up to age of 50, this patient should be given hormone therapy. Now, when we give hormone therapy, we have to also keep in mind that there's a risk that back of the mind we are worried about the side effects, breast cancer risk and other issues. But uh, the increased risk is with combined treatment and not with estrogen therapy alone. So if a patient has undergone a hysterectomy, then we can give estrogen alone. So we have to discuss with our gynecological colleagues, weighing the pros and cons, assessing the overall risk profile for cardiovascular issues, obesity, and history of breast cancer, and then have a discussion with the gynec, the risk benefit of giving these hormone therapies in patients who have early menopause. Next case, she's a 60-year-old female, left fracture neck femur, admitted in the hospital. She is treatment naive. Now, what is sad actually is that, all our patients of heart attack will get aspirins, will get beta blockers, ACE inhibitors, or ARBs for cardiac protection. In a study, 80% of patients post heart attack got beta blockers, but only 15% of patients who had osteoporotic fractures got treatment, which is a very sad situation. So now we have all our treatment options. Hip fracture is there. So what treatment we will give? So zoledronate has shown to reduce fracture risk and mortality after hip fracture. So this is a good option. Denosumab is also very effective. It significantly reduces the risk of vertebral fractures, hip fracture, and non-vertebral fracture is reduced by 20%. And keep this 20% in mind later as we talk about, I will discuss later. So we are very happy with denosumab and we see all the increase in bone density and we are very fascinated by it. But keep in mind the reduction of non-vertebral fracture risk is just 20%. So if you see with denosumab, 9.4% increase in bone density at the spine at 3 years time, and 5% at the hip. So that's great. And unlike bisphosphonates, which plateaus after 3 years, denosumab doesn't plateau. The increase in bone density continues to occur. So at the spine, you can see 21% at end of 10 years, which is great. And at the hip, 9.2% at the hip. So it's really amazing increase in bone density. What about, so there's a study called data and data extension studies. where it combined, you had teriparatide alone, you had denosumab, and you had combination therapy. So here it showed that combination therapy significantly improved the bone density compared to any other treatments. So and improved it significantly quite fast. So in 2 years, the spine increased by 12%, which is really amazing. What about sequential therapy? So if you have patients on here, the data switch study, they check if the patient was on teriparatide, they switch to denosumab, or denosumab switch to teriparatide, or combination switch to denosumab. So this was the study. And what was the important take-home message was that uh, if you transition from teriparatide uh, to or combination therapy to denosumab, you get a good increase in bone density. But if you switch from denosumab to teriparatide, you will get a bone loss, which will occur at the hip, and that may increase the risk of fractures. And that bone loss doesn't come back to baseline. So this is very important. That sequential therapy, denosumab should never be followed with by teriparatide. What about if your patient's on long-term bisphosphonates? Can you switch them to teriparatide? In this study, there will be a blunted response, which will initially be below baseline, but over a period of time, it will come above the baseline. So one may still consider in bisphosphonate treated patients you may switch to teriparatide, though the response at the hip will be blunted. In the spine also will be blunted, but not as much as the hip. What are the side effects of denosumab? Osteonecrosis of jaw, atypical fractures I'll come to. Hypocalcemia is very important. So this is something that we have to closely monitor. So at baseline, checking calciums, and after a month, repeating the calcium, I think is very important. The other thing extremely important is potential rebound fractures. These patients, I've seen that they don't come back for their 6 monthly dose. And when they miss the dose, there's a rapid bone loss that occurs. So you can see that if you are treating with denosumab, there's a rapid increase in bone density. So this is at 2 years of treatment. But if you stop it within 1 year, you lose all that gain that you have had. And with the rapidity of the bone loss predisposes one for a increased risk of fractures. And I think in the next few years, we are going to see a lot of this because there's a lot of abuse of denosumab that is happening. And there's also lack of compliance from patients because osteoporosis is silent. So they take it only when they have some symptoms, they will be taking it and then they miss out. And there's lack of counseling. So this is something which is very, very important. So how do we prevent this bone loss from occurring? One dose of IV zoledronate should be given to these patients at the end of 6 months of the last dose to prevent significant bone loss to occur after stopping denosumab. Now, teriparatide traditionally has not shown to reduce the hip fracture risk, but the trials were not there. So meta-analysis have clearly shown that it reduces fracture risk at the hip by 56%. So patients who are treatment naive, even post hip fracture, one can consider giving teriparatide to these patients. The side effects, common side effects are they can get local site reactions, which are common. Occasionally they get dizziness, nausea, leg cramps. Those are quite rare. Hypercalcemia is something that we have to watch out for. And the way to manage is that, so we have to check the calcium just before the patient is due for that dose. For example, the patient takes it at 9 a.m. the dose. You check the blood test at 9 a.m. and then the patient can take the injection. So the calcium levels, if they remain high, what you do is you reduce the calcium intake, so reducing the calcium supplements, and then try to manage the hypercalcemia. We should not be giving to patients who have a history of kidney stones, especially who have hypercalciuria, because that again predisposes them to getting renal calculi. I had a patient who was given teriparatide by somebody and developed multiple kidney stones and had UTI and sepsis. And he had given history of kidney stones in the past and hypercalciuria in the past, which was there, and that was not, so you should not be doing that. Uh, then osteosarcoma, now it's related only to animals that there was a black box warning by FDA, but that has been removed. So it is a rat problem and not a human problem. But still, that osteosarcoma, to prevent it, the certain precautions have been suggested. So we don't use in Paget's disease, with history of prior radiation therapy, bone mets, and history of skeletal malignancy. We don't use teriparatide. It's a relative contraindication. So next case, 68-year-old female, low back pains in 1 month, she had with moderate intensity. This was in June 2019, and I'd seen this patient. She was she was wife of a big industrialist, and she had this vertebral fracture, and she just had some history of tribal, and she had a fracture, and BMDs were low at the spine and the hip as well. And we evaluated, looked for protein electrophoresis, PTH. There was no M band, PTH normal, and we discussed option of teriparatide. Why discuss option teriparatide? Because it's very clear, patients with vertebral fracture compared to bisphosphonates, new vertebral fracture risk is significantly reduced with patients who receive teriparatide compared to anti-resorptives. Also, I told you about the non-vertebral fracture risk, which was 20% with denosumab, but 53% with teriparatide. And the reason for this is that it's not only about bone density, but also anabolic agents like teriparatide, romosozumab also improve the bone quality and the microarchitecture, which is very, very important for fracture risk. The patient said he will think about it. She will think about it. The pain is not so bad. She came a year later, on 2021, 2 years later, with a right hip fracture. So the fracture risk is highest. So there's something known as imminent fracture risk. If somebody has a fragility fracture, osteoporotic fracture, the risk of another fracture in the near future is very, very high, which then wanes over a period of time. For this patient, we gave combination therapy of denosumab and teriparatide. At the time, romosozumab was not available. Now, romosozumab is anti-sclerotin antibody, extremely effective, very good. You have had multiple trials like the ARCH study and the FRAME study, which have increased the bone density at the hip by 6%, which is amazing. And this is 1 year. You compare that and also the spine. You see over 13% increase in bone density at the spine with romosozumab, which is really amazing. But sequential therapy matters. So if the patient has been on a bisphosphonate, like the hip, you can see the response is blunted, is half. But the hip is 2.9%. Spine also gets blunted after using bisphosphonates. What about denosumab? After denosumab, there's really no much benefit at the hip and less than half response at the spine. So if a patient on denosumab, it's not that much, not that a great idea to switch them to romosozumab. But if the patient's on bisphosphonates, one can still do that. I'll just say a couple of things about romosozumab. So just for the students, it's a once a month injection for 12 months. Very effective, very good. It's one of the best treatments available right now. The contraindications are if a patient had a stroke or a history of myocardial infarction. So that is when it's a contraindication. We monitor for hypocalcemia. It has a dual action, anabolic and anti-resorptive properties there, and it's very, very, very effective. Next patient, 50 to 54-year-old female, spine BMD. In 2014 was 7.786. In 2015, it has decreased to 0.710. There's a 9% decrease in bone density. The patient is very upset. You are on treatment, doctor, and I have lost bone density. But if you see the scans, the labeling of the scans are incorrect. And it's not possible to lose 9% bone. Accelerated bone loss is 1.5%. If you get something non-physiological, then it's likely to be something due to the scans. So we must compare the same region of interest. The 64-year-old female, DEXA's has a spine has increased from 0.820 to 0.865. And the patient is very happy. But actually, are we really happy? But if you look at the scans, there's a compression, vertebral fracture. And this vertebral fracture is falsely increasing the bone density. So what is treatment failure? Now, technically, all osteoporotic fractures have a certain fracture risk reduction, like bisphosphonates, 50% fracture risk reduction is there. So by nature, 50% time patient will fracture. So does the one fracture indicate or tell that the patient has had a failure? The answer is no. So there is a certain definition that is there made by experts. So 2 or more incidental fractures, or if a patient has had one fracture and where the bone turnover marker is sort of not changed. Like with anti-resorptives, you should get a suppression of bone turnover marker like CTX. But suppose if that has not occurred, or there is a decrease in BMD or both. So that is when you will say that there's a treatment failure. So fracture uh, and elevated CTX, or no significant decrease in bone density, or a significant decrease in bone density. And other thing to keep in mind is that fractures of hand, skull, digit, feet, ankle are not fragility fractures, so they are not osteoporotic treatment failure. So if patient has had a basically fracture on treatment, depending on what treatment, for example, oral agent bisphosphonates, you switch to anabolic. Like the patient who had a vertebral fracture, I will switch them to teriparatide or a romosozumab. But if a patient is on denosumab, then what do you do? Or then those patients you will add on teriparatide and make it a combination therapy. You can't switch from denosumab to teriparatide because that will be counterproductive. And even switching from denosumab to romosozumab, you may not get that much of benefit. Next case, 68-year-old female RA on methotrexate 20 mg per week with steroids, arendronate, and has lateral thigh pain. Now, this patient is on long-term bisphosphonate therapy, having lateral thigh pain, and she had come for a second opinion, saying that her RA is not controlled. I just got an X-ray done, and you can see that she's had the small there's increased sclerosis and there's the crack here. So the lateral fracture crack here that's happening. And this is a typical subtrochanteric fracture because of long-term bisphosphonate use. So the more you use your bisphosphonate therapies, the higher the risk of atypical fractures, with also denosumab also. Now, the other also thing is that bisphosphonate meaning oral bisphosphonates. With IV zoledronate, with our standard osteoporotic doses, there is no data or increased risk of atypical fractures happening with IV zoledronate patients. Now, also other thing to keep in mind is that atypical femoral fractures also occur in patients who are not on bisphosphonate, like patients who are diabetic, patients on steroids, chronic PPI users. So there are other reasons also for these atypical fractures to occur. But these fractures are extremely rare, and it's very clear that treating osteoporosis, we are saving more fractures than having these atypical fractures. Next case, this is a patient of rheumatoid on hydroxychloroquine, sulfasalazine, alendronate since 3 years, and dental implants have been planned, and they referred for clearance. Now, what the dentists are really scared of is this osteonecrosis of jaw because of adynamic bone disease. So, like atypical fractures, and this is because of adynamic bone disease that occurs. But it's extremely rare. So, there's a joke that the risk of ONJ is significantly less than any fractures. It is more risk with anaphylaxis or death by accident or death by murder, and it's similar to getting struck by lightning in New Mexico if you take the risk of ONJ. So extremely rare. With denosumab also the risk is there, but again extremely low. Now the patients who actually are high risk of ONJs are those patients who are very sick. The patients who are oncological patients, diabetes, history of radiation therapy is there, who are on steroids, advanced age, they have dentures and multiple teeth extractions. See, cavities and root canals are not an issue. The issues are extractions and implants. So a recommendation is by the American Dental Association is that we try to optimize their dental health before starting these treatments. And if they are on treatment for example, with oral bisphosphonates, if they're less than 4 years and no risk factors, then we just continue. But if they have some risk factors, like on steroids, then consider drug holiday for at least 2 months or if they have a bisphosphonate used for more than 4 years, then again consider a bisphosphonate holiday. But honestly, these drugs remain in the bone for long duration, and how much actually this is going to prevent ONJ is very we don't know. For denosumab, we should plan our procedures just prior to the next dose of denosumab because the effect goes away, the healing occurs, and then we can again restart denosumab. So because of all these issues of atypical fractures and ONJs, we can consider giving patients a bisphosphonate holiday. And if the patient becomes a low risk, for example, if the bone density becomes better than a hip score becomes better than 2.5, and they had no history of fractures in the past, then one can consider giving them holidays for a drug holiday for 2 to 3 years. So for oral agents, it's around after 5 years we can give the holiday. With IV zorantonate, after 3 years we can give a drug holiday if the fracture risk is low. Now, I discussed in the previous part was that bone density alone, we are missing out fractures. So 50% of fractures occur in the normal and osteopenic zone, which is a big number. Though the fracture risk is highest in the osteoporotic zone. So we're missing something out. What we're missing out is the bone structure, the bone quality. And there are different ways to look at it. So we can look at it by using methods like QCT, or we can use something known as trabecular bone score. So trabecular bone score is basically a software installed in the DEXA machine, which will assess the microarchitecture. So it uses a grayscale index like this. And if the microarchitecture is good, you get a good score. If the microarchitecture is poor, you get a poor score. So it correlates with the bone microarchitecture. It's like this. So having Eiffel Tower made of wood, and Eiffel Tower made of metal. Obviously, metal is more stronger. But if you have Eiffel Tower made of metal, both, but the microarchitecture is again poor. The one on the right, the last Eiffel Tower, is at high risk of collapsing. Similarly, if the microarchitecture is poor, even though the density is the same, the metal are the same things, uh, it will still increase the risk of fractures. And this has been validated. It is part of the FRAX scores. Okay. If we use TBS, we'll be reclassifying almost 30 patients of osteopenia to osteoporosis, which is a huge number. So there's a here an option adjust with TBS, and we have to put in the value here, and it gives us a revised score. Let me show some cases how we should use optimally these new technologies of DEXA. The 72-year-old female, she has no complaints. She's osteopenic, but her bone microarchitecture is normal, fracture risk is low. But on the lateral DEXA, she has 3 vertebral fractures. This is the patient I picked up, and then she was diagnosed with multiple myeloma. This is the patient of RA-ILD, normal bone density, but has a mild vertebral fracture. So something that we wouldn't have treated, we are treating now. You can see that the bone quality is poor. So the trabecular bone scores get significantly affected and more by steroid rather than the bone density. So if a patient on steroids, the TBS values get first affected and then the bone density gets affected. Also, I told about that 10% of fractures happen in the normal range, and about half of them have abnormal TBS values, have low TBS values. So what appears as normal bone actually not normal. This is the bone microarchitecture is poor. This is the patient who is diabetic since 12 years, osteopenic, no vertebral fractures, but very poor bone quality, degraded microarchitecture. So the fracture adjustment TBS, you can see, has crossed the treatment threshold. So somebody who we wouldn't have treated, we are treating now. So diabetic patients and patients on steroids both have lower TBS compared to the other population. This is a patient of lupus with -3 and no vertebral fractures, but very low bone quality. So I need something that will improve the bone quality. And what improves bone quality are anabolic agents like teriparatide. So I treated this patient with teriparatide. This is a 63-year-old female, fell in the bathroom, had back pain. and you can see a vertebral fracture here. So just to summarize the treatment, when we use to diagnose osteoporosis, we should use the best technologies. I know most centers will have only bone densities. If that is the case, then you should use lateral spine X-rays in patients who are above 60, female above 60 and men above 70, or if they are on steroids. Every year, a lateral spine X-ray should be done because otherwise we'll be missing out silent vertebral fractures. If they are early postmenopausal without fractures, hormone therapy, very important. If they are late in 50s and 60s without any fracture, then we can consider IV bisphosphonate therapy or oral. Women in late 60s without fracture or major risk of fractures, again, IV bisphosphonates or denosumab. But if a patient with any recent fractures, multiple fractures, very low bone densities, or where the T scores at the hip are -3 or less, or they have very low poor bone quality, then anabolic agents should be considered first line. Because if you use anabolic agents first and then followed by anti-disruptors, the gain in bone density and the fracture risk reduction is any day superior to starting anti-disruptors first. Combination of denosumab and teriparatide or romosozumab in very high-risk patients are very effective. Sequential therapy, anabolic followed by anti-disruptors preferred. Don't switch from denosumab to teriparatide. And we must use IV zoledronate after using denosumab. Thank you so much.
Thank you, Dr. Puneet. That was an excellent talk. We have a few questions in the chat box. We'll just finish quickly. What are the precautions that should be taken in patients with chronic kidney disease or coronary artery disease while treating osteoporosis?
Okay, all right. So with CKD patients, you have to decide whether what stage of CKD is it. Is it stage 1, 2, 3? Well, if it's stage 4 and stage 5, then you have to differentiate, is the low bone density because of renal osteodystrophy or basically renal bone disease. So we have to use markers like PTH and bone-specific alkaline phosphatase to identify the bone turnover. What is the bone turnover? Is it a high, am I dealing with a high bone turnover state or a low bone turnover state? And then decide your treatment accordingly. So if it's a high bone turnover state, then one may use denosumab. But if it's low bone turnover state, then we don't use denosumab. Stage 1 to stage 3, you will treat like normal osteoporosis. Uh, yeah, and regarding coronary artery disease patients, you will treat like any other osteoporosis patient, except you will not be giving them romosozumab in this group.
Okay, romosozumab, there's any warning or is just because they've not tried it?
So there was a study called ART study, which was there, which where they compared romosozumab to alendronate, and it was found that the patients who are on romosozumab, there was a signal that there was an increased risk of increased cardiac and strokes, heart attack and strokes compared to the alendronate group. But in the FRAME study, that was not shown. So there are two major trials. One trial showed a signal of cardiac, and other did not. Uh, so based on that ART study, the FDA has said that if there's a recent myocardial infarction or stroke, we must not use romosozumab.
Okay. I think you've partly covered this. In diabetics over 55, how should you manage osteoporosis?
Very good question. So you must assess the fracture risk overall. So number one, has the patient fractured? That's the first question. If the patient has fractured and treatment naive, we must give anabolic agents first. If the patient is not fractured and the bone density is low, then you decide treatment. So example, I spoke about trabecular bone spurs, but not every center has TBS. So how do we decide treatment? So the cutoff, because these patients who are diabetic, they fracture at higher bone density. Patients who are diabetic, we should treat if the T scores are -2 or less. So the cutoff of diabetic patients is -2 or less. And then you decide your treatment. You can give them bisphosphonates. I would not give denosumab so early in their disease. To 55-year-old lady, I will not give denosumab. And the reason I'm saying that is that then practically you are not you will not be able to give anabolic agents practically. So these are the groups that early, if I have to treat, then I will give bisphosphonates. Yeah.
Is abaloparatide available? Is it better than
No.
teriparatide?
Yeah, it is not available, but it's better than teriparatide. So the advantage of abaloparatide is that it has a higher increase in bone density at the spine and the hip. And abaloparatide not only works in the hip area at the cortical level, but also at the not only the trabecular level, but also the cortical. So teriparatide works mainly at the trabecular level at the hip, but not at the cortical, while abaloparatide works at both. It is superior, but not available.
When we do serum calcium levels, as you said, do you look for hypo or hypercalcemia? And do you do ionic calcium?
Same plain serum calcium should be enough. With albumin, you should have. So you get actual value. And so it depends your calcium when you're monitoring. We're looking for both the things, but it depends what treatment you're giving. For example, if you get anti-resorptives, then you're looking more for hypocalcemias. If you're using an anabolic agent like teriparatide, you're looking for hypercalcemia. So yeah.
Okay. In patients of lupus, many of them have osteoporosis. So they are young. So what do you do?
Yeah. If they're premenopausal and not fractured, I will I will not I may observe. So there is a ACR recommendation for use of the when to treat for with bisphosphonates and all, depending on the dose, depending on your Z scores and fracture risk. So it is available we just follow that guidelines in the ACR 2022 guideline is there for GLP. There's a flow chart. I would suggest all the students to go through that. There's detailed, it is mentioned. So that's it. That is a talk by itself. So I have not really shown that. But you can go through that. So young individuals, I will be skeptical in treating uh, if there's no history of fracture. Yeah.
If there is already a fracture, say a vertebral fracture in a lupus patient,
Then anabolic agent, you have to give teriparatide. If there is a vertebral fracture or any other fragile fracture, I will consider giving anabolic agents.
but after that we'll have to stop. I mean, like that is for 18 months, for 2 years. No?
Correct. So then we have to manage it. So sequential therapy, when we are giving, if you give anabolic agents also, and we don't follow it up with any sequential therapy, you're going to lose the bone density. So then you have to, after teriparatide, you will have to give one dose of ivizolnurate. And then these patients, we assess the risk actually. So these patients are on steroids. Then we will continue to give some bisphosphonates for some time. Then you will not be much off. Yeah.
Is there any use of doing bone turnover markers before starting treatment in every patient, if according?
Yeah. So I'll tell you what. So actually, so in terms of bone turnover markers have to be first of all done in a proper way. It has to be fasting. The lab should be close by. The processing unit should be close by because if it is not done properly, then it's not going to be reliable. Now, using bone turnover marker, for example, for denosumab doesn't make sense. You know that the bone turnover marker is going to get suppressed. So there's no point doing when you're using denosumab. It makes sense if you're using bisphosphonates because they have a longer sort of a set-off period. The bisphosphonates bind to the bone for a long period of time. So that is the group when I may consider if I'm going to be treating a patient for long term, then I may use a bone turnover marker as an add-on tool to monitor these patients, especially when I'm trying to give them a bisphosphonate holiday.
Okay. Okay, I think there are no more questions. Thank you so much. It was a very nice talk. Thank you for sparing your Sunday to join us in this session. So thank you, Dr. Puneet. Thank you, Dr. Kaustubh and Dr. Shubda for being and all the attendees for today's program. Have a great day. Yeah. Thank you. Bye-bye. Yeah.
Thank you, Kavita. Bye.
Thank you. Bye-bye.
Yeah. Take care. Bye.